Hi folks, this is Dr. Rob Cyrus. I'm the Carb Addiction Doc, and a little while ago in January of this year, I gave a talk at the Low Carb USA Summit in Boca Raton, and they had a special day, the Type 1 Diabetes Day. And we've done an analysis of 1,093 Type 1 diabetics that we've managed for over 4 years, with an average A1C at 5 years in the low fives. And as part of that, which is ridiculously good, but as part of that analysis, there's a cohort of type 1 diabetics called the type 1 grit folks. Really like them. I love what they're doing. They're on Facebook. They're part of the ketogenic movement. They are huge accolades or followers of Dr. Richard K. Bernstein, who's been a mentor for me. And Richard Bernstein is absolutely phenomenal in terms of changing around the entire approach to diabetes, type 1 and type 2, to changing the concept, but particularly type 1, since Richard has type 1 diabetes himself. And he's a mentor for me, absolutely brilliant work that he's done, and mind-altering methodology change. However, I got pretty heavily criticized about a concept that I discussed. And one of the things to understand is I'm in the trenches. I manage 15 to 20 patients every single day, every weekday. So I'm in the trenches. I do tons of blood work on patients. Without being arrogant, probably more blood work on more patients in the diabetic space than any other physician, at least in the ketogenic space. And so over the last 23 years, certain trends and certain pathways and patterns have become knowledgeable. And there's a particular issue that this type 1 grit group had with the way I manage my patients. Remember, our results are our results. They're really good. Okay, and you can argue with the result. Now we get the argument, hemoglobin A1C isn't the only. It doesn't matter. I'm not here to piss anybody off or to argue. I'm here to promote science that we've seen, physiology. So obviously type 1 diabetes means that your pancreas produces almost no insulin, or certainly less insulin that you need to function from an energy dynamic perspective as a human being, and you therefore have to supplement with injected insulin. Type 1 diabetes is a deficiency of adequate insulin to manage your blood sugar that requires injectable forms of insulin. Okay, and it can take the form of autoimmune type 1 diabetes or the death or removal of pancreatic cells. So if you've had a total pancreatectomy, you can get type 1 diabetes. If you've had a virus that's destroyed your pancreas, or you've got autoimmune disease, those are the common forms. And we manage those. Then there is type 2 diabetes, which is primarily insulin resistance. And I'm going to talk about type 2 diabetes because that is the dominant thing, even though we're talking about type 1. A little confusing. And then we're going to talk about people who are enormously obese, like myself, like I used to be, who are not diabetic. Because in order to understand how we manage our diabetics early on in their treatment, that's what we're going to talk about, okay? So pretty much every type 1 diabetic that is managed in the standard endocrinology methodology is being forced to eat carbohydrates as snacks and to being forced to eat carbohydrates as meals, and then using their dosing of insulin that is calculated by how much carbohydrate they're eating. They're using a certain mathematical formula to dose their insulin based on how much carbohydrate they're about to eat. And the problem with that is that when you are eating carbohydrates in a chronic excessive way, which also is true for diabetes, type 2 diabetes, and is also true for obesity. Obesity, type 2 diabetes, and the way type 1 diabetics are managed by the standard glycemic index endocrinologists is all three are a form of chronic excessive carbohydrate consumption, and the damage in diabetics occurs because of those chronically elevated blood sugar levels. Damage occurs in the blood vessels and the interstitial space where the ligaments, the tendons, the nerves run, okay? High levels of sugar damage those blood vessels. However, okay, so that's true for type 1, we can have a type 2 component. Now, if you're not eating carbohydrates, you can be a pure type 1. If you're not eating carbohydrates, then all you need as a type 1 is enough insulin to get a little bit of sugar that your liver is making into the cells, because it's not coming from your mouth. The majority of type 1 diabetics, the majority of their carbohydrate come from their face. So, and certainly type 2 and obesogenic people, the same is true. I was recently with a colleague and a friend of mine by the name of Ian Lake. Guy lives in the UK, he's a family doctor. He's also a type 1 diabetic and an endurance athlete. And he just blew my mind. He presented something called a 0-5-100. Now these guys are nuts. He's a type 1 diabetic. He fasted for 5 days, no calories for 5 days, ran 20 miles a day for 5 days, which is the 100. And he looked at his insulin utilization, he's looked at his ketones. So I thought, okay, I'm not Ian, I'm not that crazy, but I also want to do that. And beginning of March, I had a race coming up. It was a preliminary race called the Gate River Run. It's a 15K. So I said, okay, let's do a 0-5-15. What does that mean? 0 calories for 5 days, run a 5K every day, it's 3.1 miles, and on the last day, run a 15K, which is a 9.3 mile race. And I did that. And I did great. It was very humid. It sucked a little bit. But because of the humidity, I used something called ketone IQ. I was running fasted, but I was feeling a little bit flat during the race. And it was very humid. I was sweating up a storm. And I added a little bit of salt to my ketone IQ. I added some Redmond real salt to my ketone IQ. And I drank one at the beginning of the race and one at the 4.5 mile mark. And I'll tell you, each time there was a little bump, a little boost. I wasn't monitoring anything. I was actually monitoring my blood sugars. Blood sugars were flat because I was empty. I hadn't had any calories for 5 days by that time. That little bit of ketone IQ, together with the water that I drank at the water stations, really helped me during that race. And I thought I was going to have a really bad time. I've run this race 15, 16 times. But I was able to really push the last 2 miles, which is up and down a massive bridge in Jacksonville called the Green Monster. Now, when you do blood work on these 3 individuals, type 1 diabetics have very, very low levels of insulin to 0 levels of insulin from their pancreas. Okay? And you can measure that. You can measure that as something called C-peptide. C-peptide, okay? Type 2 diabetes have high levels of C-peptide, so they have high levels of insulin. So the type 1s, 0 or very low C-peptide. Type 2s have high levels of C-peptide. High levels, elevated levels of C-peptide. Normal C-peptide for me in a ketogenic fat-adapted person is around 1 to 1.2. The average type 2 diabetic who is untreated on the standard American diet, eating a lot of carbohydrates, has a much higher level of C-peptide. But C-peptide, by the way, is the precursor for insulin. So C-peptide, when your pancreas releases insulin, it releases it almost looks like a football goal, like a rugby goal. Rugby's better than football. Yes, rugby's better than football. 2 goalposts with a crossbar. Think of the C-peptide as a crossbar, and then as soon as the insulin is released from the pancreatic cell, from the beta cell, that C-peptide gets removed and you've got your A and B chains, which is active insulin. But that C-peptide, we're not quite sure what it does. There are a few speculative things, but the C-peptide can be measured, which tells us how much insulin is being released by the pancreas. So even though the type 1 is injecting insulin, and if you measure insulin, you'll measure for some assays, you'll measure that insulin. The C-peptide should be 0 or close to 0. If it's above 1, they've got LADA or they may not be pure, true type 1s. That's a story for another day. The type 2s all have elevated C-peptide. Always. At least when they come in and they've still got type 2 diabetes. Their A1C is above 6.5, which makes them a type 2 diabetic. And even if they're insulin resistant, they're going to have high C-peptide. Okay? So you got 0, you got elevated. And then you've got people like me, obesogenic people, who have normal blood sugar, not low A1Cs, but A1Cs below 6. Let's just use that number. Typically, I like that to be below 5.7, but typically below 6. Okay? they have enormously raised C-peptide. C-peptide through the roof. I've seen C-peptides in the teens. Think about that. 0, maybe a C-peptide of 2 to 4, C-peptide 5, up into the teens. Fasted. Massive insulin production. So both where a normal C-peptide is 1. So both the obesogenic people and the type 2s have elevated C-peptide. But here's the difference between the two, and this is the difference between being obesogenic and being diabetogenic, is this. While these folks are insulin resistant, their cells are blocking the effect of insulin, their pancreas genetically can produce so much insulin that no matter how resistant they are, they can still keep clearing that sugar and they're not diabetic. So they can produce massive amounts of insulin and they're not diabetic. The type 2s can produce moderately elevated insulin. They're hyperinsulinemic, but not very high. And the blockage, the insulin resistance, is greater than they can produce insulin. So they can't get that sugar into the cells. Their blood sugar goes up. Chronic elevation of blood sugar causes type 2 diabetes. The type 1s, if they're not using insulin with a 0 C-peptide, well, they're going to be dead, but they're using just a little bit of insulin, their C-peptide is still 0. So they have to give themselves extra insulin. Now, if they're eating a lot of carbohydrates, they're going to be using huge doses of insulin. Big doses of insulin, just enough to clear their blood sugars. But the problem with the glycemic index is it's not enough to clear their blood sugars to normal, which is around 83 to 85, 80s maybe under 95. They're running blood sugars in the 200s, in the 150s, 160s, 140s. So they've got hyperglycemia, and even though they're using a lot of insulin, they're still not, because they're afraid of going low, they're still not using adequate insulin. So how do you get these people to bring their blood sugar down? Two things. Number one, you stop eating carbohydrates and you're going to see a reduction. But that doesn't fix insulin resistance right away. If you look at my obesogenic people, they're producing massive amounts of insulin. So if they stop eating carbohydrates, they're still going to be insulin resistant, but they don't need insulin because, or diabetic medication, because they're producing more insulin than they need to. As an obesogenic person, my highest insulin, fasting insulin, was 87 units of insulin with a blood sugar of 102. A1C, I think my highest A1C was like 5.5, 5.6. So I'm highly obesogenic. I can produce massive amounts of insulin. The type 2s can't produce that amount of insulin, but their blood sugar is high. So what my body is doing is saying, dude, here's more insulin. Let's get rid of the sugar. I gain weight very easily, but my blood sugars are fairly normal. The type 2s can't produce enough insulin, so their blood sugars are high. So to make a type 2, which is diabetogenic, into an obesogenic person, you want to give them more insulin, because that's what my body's doing. The reason I'm not diabetic is because I can produce large amounts of insulin. So what do? We bump up their insulin. And that means you have to go up in the blood, in the diabetic medication to bring their blood sugar down. Now, of course, for all of them, you want to get rid of the carbohydrates. And if you get rid of the carbohydrates, you accelerate the process. But all I'm doing is converting my type 2s or my type 1s with a type 2 component with an insulin resistant component. I'm converting them to being obesogenic. Now, in my own life, if I stop eating carbohydrates slowly, and I'm not diabetic, slowly over time, or even fairly rapidly, but it still takes weeks and months, my insulin resistance goes away. And as my insulin resistance goes away, naturally, in keeping with that, my pancreas reduces the amount of insulin I'm producing. That happens naturally in me. I'm on no medication. So as I reduce my carbohydrate consumption, my insulin resistance slowly comes down, not the next day, but weeks and months later, and my insulin levels come down. Now that process, that lowering of your insulin may take anywhere from 6 months to 2 years. 2 years. But currently where I am, 23, 24 years in, having lost 107, 110 pounds as I'm sitting here, my insulin is 3 to 4 units when I measure it. My C-peptide is anywhere from 0.8 to 1.2. My blood sugars are in the 70s and 80s. I've got a G7, it's still in the box, I'm not wearing it, but I can tell you that my blood sugars are low. And when I eat something I shouldn't eat, or when I exercise, my blood sugar will go up, my insulin comes down, I'm insulin sensitive. I'm fat adapted insulin sensitive. But in an obesogenic person, what happened is my very high levels of insulin were enough to keep my blood sugars normal, and then as my insulin resistance got better, naturally my insulin came down. Well, in the type 2s, that's not true. Their blood sugars are high, their insulins aren't high enough. So the first thing to bring the blood sugar down, we have to give them more insulin, convert them to becoming obesogenic. And if we get the blood sugar down, you've got to go up on the insulin to bring the blood sugar down. As you go up on that, as the blood sugar comes down, now the insulin resistance goes away, just like it did with me. And now I can then progressively reduce the amount of insulin. It accelerates the correction. But we have to go up to come down. And eventually, once your blood sugars are low and you're not eating carbohydrates, you can come off as a type 2 all of those diabetic medications, or maybe just be left with a little bit of metformin. But the drug that helps to release more insulin, to get the insulin up in someone who's producing a lot but not enough to bump it up, is a GLP-1 agonist. GLP-1 agonists bump insulin up and also decrease sugar production by the liver, or sugar release by the liver. So the insulin goes up automatically with GLP-1s, and that's how we treat with GLP-1s, we treat our type 2s. And we do exactly the same thing in the type 1s. We do exactly the same thing in the type 1s. So this is where the Bernstein evangelists, they don't understand this concept. So what do we do with our type 1s? Well, using insulin, but their blood sugars are still running too high. How do we get that blood sugar down? How does a type 1 get their blood sugar down? Number one, they don't eat carbohydrates. And number two is they have to use more insulin. So if they look at their Dexcom and the Dexcom's reading high blood sugar, what do? They dose with insulin. And they may go from 160 down to 140, but I want them in the 180s. And we do that slowly, but we do that slowly by going up on the insulin, or maybe adding a GLP-1, which blocks sugar production by the liver, and they're not eating, they're on a ketogenic diet, but we have to go up on the insulin to slowly bring them down. And if we do that, we bring the blood sugar down slowly by going up on the insulin. But they're not eating carbohydrates. They have to not eat carbohydrates for this model to work. And then once their blood sugars are down, the insulin resistance goes away, the type 2 goes away, and they can reduce their insulin utilization. So as an anecdote, I just had a patient, young guy, blew a retina, 31 years old, type 1 diabetic for most of his life, was using 90 units of insulin. We got rid of the carbohydrates. The first couple of weeks, he had to go up on his insulin, so he was using 120 units of insulin. But pretty quickly as a type 1, he came down. And after a few weeks, after a few months, he's about 3-4 months in, he's now at below 30 units of insulin, having gone from 90 to 120 and back down to 30. But he probably would have been higher if he hadn't gone up to come down. And for him, because he's basically went from high carb to carnivore, which a lot of people struggle with, he did amazingly well. Eyes better, salvaged his eye, much better glycemic control, just because we helped him to change his methodology. So the way we manage diabetics, type 1, type 2, insulin resistance, we treat your blood sugar. I don't care why your blood sugar is high. I don't care why your blood sugar is high. You bring that thing down, because that's what my pancreas does as an obesogenic person. It doesn't care why my blood sugar is high, whether I've exercised, whether I haven't slept, whether I've eaten carbohydrates. My pancreas is really good at releasing insulin. When in the 2s and in the 1s, they don't have enough insulin, so give them some. But if you get rid of the trigger, if you get rid of the carbohydrates, that normalizes. That is why in our program you go up to come down, but the end point is to be on super low doses. But the only thing that matters is your blood sugar. And you don't want to be adding to blood sugar by your mouth, but you still have to tame your liver. And the GLP-1s in type 1s are excellent. They work amazingly well, not forever, but to get rid of the type 2 component, just like we do in our 2s. So I hope that that explains it. Because the only difference between a type 2 diabetic or a type 1 with a type 2 component and myself is the amount of insulin the pancreas can produce. Whether you're a 1, whether you're a 2, or whether you're me. No C-peptide, too little C-peptide, but elevated, massively elevated C-peptide. No diabetes, type 2 diabetes, type 1 and type 2 diabetes. Elevated A1C, which is the type 2 component. Elevated A1C is a type 2 disease. It's not a type 1 disease. Okay? So why don't I have diabetes? Because I produce a massive amount of insulin. Well, let's get everybody to have a massive amount of insulin, and then we slowly lower it until you're where I am. And everybody should be at a very low level of insulin production. Certainly the 2s and me, and the 1s can give themselves very small doses of insulin, equivalent to what my pancreas does. That's the rationale. And guess what, folks? I have the data on my 2s and my 1s to prove that that works. But we treat sugar, blood sugar. We don't treat diet. We stabilize the diet and we vary the amount of insulin. What the current endocrinologists do is they vary the diet. You must eat this amount of carbohydrate so that they can keep their insulin dosing stable, which is ludicrous. That's not how my pancreas works. I hope that that explanation helps people to understand what we do, but our results bear fruit or prove that this works. You don't want to be eating fruit. Give fruit to your endocrinologist. I am the Carb Addiction Doc. I hope that helps. I hope you can understand that. Please leave comments. Please leave questions. But that's the rationale of going up to come down. When you're driving around an oval in North Carolina, you got to turn right to go left. That's Lightning McQueen. Or actually Doc Hudson from Lightning McQueen. Same thing with diabetics.